Today we are on the third lecture of the fetal imaging series. In the past two lectures, we have been discussing about early pregnancy and in the early pregnancy till almost 11 weeks, right? So we have talked what normal things occur in the first trimester. We have also talked about what abnormal can occur in the first trimester, like we've talked about ectopic pregnancies, we have talked about anembryonic pregnancies, the miscarriages, and then the molar pregnancy. So now the timeline of the fetus would be 11 to 13 weeks, right? Now the fetus has grown big and it has become 11 to 13 weeks, and we have already read that the organogenesis is completed by 10 weeks. So it has all the organs that have been developed. So at this point of time, 11 to 13 weeks, we always advise this scan. And previously, I've also told you that according to ECO guidelines, the first ultrasound that has to be offered to the patient should be at 11 to 13 weeks. Now, why is it so important to do a scan at 11 to 13 weeks? We have to understand that. So one reason is that the screening of aneuploidy is possible at 11 to 13 weeks. We all are aware of that we can screen for aneuploidies, right? And this is a major chunk we used to study during our MBBS time, that 11 to 13 or the level 1 scan, also called as a nuchal scan, where we are measuring the NT and the NB, that is nuchal translucency, and the nasal bone. It used to be the level 1 scan for us. And we knew that at this point of time, we do some biochemical markers that used to be dual test, right? So we were never reading about anything that apart from aneuploidy screen at 11 to 13 weeks during our MBBS, or maybe perhaps during our entrance time. So, but now the focus has shifted. Why? Because if you see the prevalence of aneuploidy is less than 1%, right? We are so much behind aneuploidy. We are so much behind running for fetal defects. But if we understand the prevalence of aneuploidy, it is less than 1%, right? But if you talk about the prevalence of hypertensive disorders of pregnancy, so if we talk about hypertension, it is developing in almost 10% of the females, right? So 10% of the females will develop hypertension during pregnancy, right? This hypertension can lead to a lot of consequences in both mother and fetus. So in the mother, it can lead to pre-eclampsia. If this remains uncontrolled, it can lead to eclampsia. And we also know that pre-eclampsia itself is it's a very disabling condition, right? So if we talk about various disorders that can occur during pregnancy, if we talk about various hypertensive disorders that occur during pregnancy, it could be just simple hypertension, right? We can be talking about simply gestational hypertension. We can have pre-eclampsia, and we can also have eclampsia, right? So why is it so important? Why am I stressing too much about this hypertension? Is because one, the prevalence is about 10%. Second thing, it is a detectable condition. If you diagnose pre-eclampsia at 11 to 13 weeks, you can actually change the outcome of this pregnancy, both for the mother as well as for the child. So here, if if the mother has hypertension or she develops preeclampsia, so what will happen? Now the uterus is here and it is supplied by the uterine arteries. We all know that it is supplied by the uterine arteries. Now the blood pressure remains high in the uterine arteries. So what will happen ultimately? It will start to reflect on the fetus side, right? It will start to reflect on the fetus side, the increased blood pressure, and then it would lead to abnormal placentation. Apart from the abnormal placentation, the fetus will receive less blood flow. Because of the less blood flow to the fetus, it will suffer from the fetal growth restriction. So if you see the prevalence of FGR, it is about 50% in India. So it is quite high. So that is why aneuploidy is an important component of 11 to 13 week scan. But even more important component would be screening for pre-eclampsia and FGR. So is it possible? So yes, it is possible. So the ultrasound that we do at 11 to 13 weeks, actually it is 11 to 13 plus 6 weeks. So the ultrasound we do is not just nuchal scan, not just NT-NB scan. We do this ultrasound to include a lot many things. One component of the ultrasound would be right aneuploidy screening, but the other components would include screening for preeclampsia, screening for FGR, and we also screen for preterm, right? We can predict whether this delivery would last till would occur at 37 weeks, or if there are chances that this pregnancy would occur much before that, right? So and apart from all of these, we also do a detailed level 1 scan, where we are going to see everything that we see on the level 2 scan. So we are going to see for structural anomalies, right? So, this aneuploidy and the structural anomaly part, I'll be taking in a separate lecture. Today, at 11 to 13 weeks, we'll be focusing ourselves on preeclampsia, preterm, and FGR, right? So, coming on to the definitions, as I told you, if the gestational hypertension, gestational hypertension is defined as if there is only increase in the BP, right? So one is the pre-existing hypertension. The other will be the hypertension that has occurred during the pregnancy, right? So we define it as blood pressure more than 140 by 90, at least on 2 occasions, right? It has to be at least on 2 occasions and should be measured with an interval gap of 4 hours, right? So till here, no problem. Next thing, if this blood pressure increase is complicated by proteinuria, right? Proteinuria, then we start calling it as preeclampsia. So preeclampsia is having an elevated blood pressure, but simultaneously there are other things also that are occurring. Whenever the woman is going for a antenatal surveillance, then the urine dipstick test is done. So the urine protein will be plus plus on the dipstick test. If you measure when such a high protein levels would be seen, then obviously the measurement would be done. So 24-hour urine protein is done, and it shows more than 300 milligram per deciliters, and the urine protein by creatinine ratio would also increase, right? So this is called as preeclampsia. If or apart from the proteinuria, if there is any new onset organ dysfunction, then also it is called as preeclampsia. So one thing I want to say, gestational hypertension usually develops after 20 weeks, right? So not before 20 weeks, because then it will be a pre-existing hypertension more likely. So it usually occurs after 20 weeks of the pregnancy. But at 11 to 13 weeks, we are going to predict if this woman is going to develop this hypertension or not, right? Second thing that I talked is eclampsia. Eclampsia means that this hypertension and everything is complicated by seizures, right? So after the definition, if I talk about the prevalence, this pre-eclampsia, as I told you, it is around 10% the prevalence is there in India. Worldwide, the prevalence is around 2 to 5%. So it will depend upon the ethnicity. Next thing is, what are the consequences of this preeclampsia? So we have to understand that two things are happening. One is on the maternal side, and the other will be the fetal side, right? So both are getting affected. Mother, more than 50,000 deaths worldwide, they're attributed to preeclampsia. Whereas if you see for the fetus, the fetus can have in uterine death. You can have in uterine death still, but you have to understand now, when the blood pressure start to affect, the management becomes very difficult, because for the maternal indication also you need to deliver this baby, and if you deliver this baby for the maternal indication, one, the baby was weak, it was suffering from FGR. Now you're taking it out early as well, so this baby will also be preterm, right? So there will be complications of both preterm as well as FGR, and this fetus will have a long term bad neurological outcome. They will always have a even if they're born on time, these fetuses will have increased lifetime risk of cardiovascular diseases, So cardiovascular diseases, even diabetes, even hypertension, even obesity, all these risks would increase for these babies. On the maternal aspect, if you see what would happen, one, they can be death. If the mother doesn't die, what would happen? You must have seen so many women with in hypertension with swelling. So there is renal dysfunction. There is even in the neuro, you must have seen that there can be stroke, right? There can be brain edema, so BIC. There can be pulmonary edema. There can be even blindness. And then again, after the pregnancy, also these women, they are at increased lifetime risk of cardiovascular diseases. So that is why we need to understand how can we do it. So why is it happening? Let us